In this case, we decide to use a relay triple branch thoracic stem graft system from Terumo Aortic. The following are the most important measures: 29 in P2, 23 in P3 near the BCT, 29 in distal arch, and 30 in the descending. Here you can see relay triple branch graft key points. In the following slides I show you size and limb graft length simulations. And this is how looks the three limbs we choose for this case. We decide to perform a surgical approach to the neck and left arm and bilateral femoral percutaneous accesses. After bilateral ultrasound puncture, preloading two prostyles in the right groin, we placed a Landerkis guide wire and a Centron 16 brace introducer. Using an amplet left catheter and a Terumo hydrophilic guide wire, we try to cross the aortic valve, as we show in the images. When we cross it, just advance the amplet left catheter left in place, and then just change the guide wire for a super one using a double curve Landerkis Cook Medical guide wire. Now, when we have our super wire in the left ventricle, it's time to remove our Medtronic introducer from the groin and just put our relay triple branch system, that is a 25 French system. We can advance the whole system just to the proximal descending aorta without any problems. Now we can orientate the graft so that the radiopeg marks are facing to the external aortic wall in the major curvature. At this point, by placing the delivery selector in position 1, we can advance towards the aortic arch without any problem. Once we have our endoprothesis in the aortic arch, it's time to perform our first angiography to mark coronary arteries and supraortic trunk. We made our lead adjustments and just prepare to step 2. Step 2 is one of the most important steps in the release of the relay triple branch device. We initiate rapid pacing through the jugular axis and begin to release the endografts. As soon as we have the proximal part fixed in a smooth and continuous movement, we release it completely. Now it's time to stop rapid pacing. In the following replay, we can see more detail the main body endograft release. In step 3, we unlock the proximal clasping, and then we move to step 4 and we can make the complete graft removal. As you can see in the screen, we extract the entire endograft as a unit and then just downsize it with the 16 French introducer that we have previously used in the beginning of the surgery. Now, using a pigtail coming from the right groin, it's time to perform an angiogram just to check the patency of the coronary arteries and the whole supraortic trunks. If we don't notice a type 1A endoleak, we can move the C-arm and start working in the supraortic trunks. We cannulate the posterior tunnel, which is the one that corresponds to the BCT, with a Terumo guide wire and a short burn catheter. Once inside, we change the guide for a short floppy Boston amplats and the catheter for a regular pigtail. We try to remove it to see how it engages at the region of the tunnel to make sure we are well positioned. We make an angiogram just to mark the bifurcation of the BCT and decide which lens we will use in the BCT limb. In a retrograde way, coming from the neck through the right common carotid artery, we release through a limb just below the BCT bifurcation. Now it's time to move the arm again and make the same procedure to the other tunnel, the one for the left common carotid artery. We use the same kind of guide wires and catheters and then just release the Terumo aortic limb in the left common carotid artery. After removing the trio limb from the left common carotid artery in the neck, just we close the puncture site and make an angiogram from the groin, showing the coronaries and the supraortic trunks again. To finalize the procedure, we must cannulate the third retrograde access tunnel to the subclavian artery. For this maneuver, we use the humeral surgical approach and cannulate the retrograde from above to make the procedure easier. Once we are in the descending thoracic aorta, we just snare the guide wire from the right groin to make a through access. We use a regular pigtail through Terumo guide wire just to make the correct measurements to the length of our graft in the left subclavian tunnel and artery. At this point, it's crucial and mandatory to see the origin of the left vertebral artery in order not to cover it. In our case, we selected to use a self-expanding Gore Bioban endograft of 10 mm in diameter by 100 mm in length that fits perfectly to our purposes. When our Bioban is in place, we simply perform a slow and controlled release of the Bioban to avoid sudden movements or displacement of the graft. To avoid future kinkings or local compressions of the Bioban, we decide to reinforce this branch with a coaxial self-expandable stent. We choose a Biotronic Astron stent of 10 mm in diameter by 80 mm in length. We place the auto-expandable stent via the brachial approach and then perform a soft angioplasty with a 10 by 40 mm balloons in 3 different positions. With a vertebral catheter coming from the groin, we just check the patency of the vertebral artery and the left subclavian artery. After removing all our support guide wires, we just left the pigtail in the aortic arch and make our final angiogram. We can notice correct patency of both coronary arteries and all the supraortic trunks, including the two vertebral arteries. And this is how our relay triple branch looks like in the first control angio-CT scan. You can notice correct expansion of the main body and limb endographs with patency of all the vessels involved in the arch. Also, you can notice absence of proximal, distal or connection leaks.